Vivek will continue with the talk on traumatic optic neuropathy and its management principles. So Vivek, over to you.
Yeah, so thanks, Ami, for giving me opportunity to present in this quite interesting IC that I could see a couple of talks and it was quite educative. So basically, I do not have any financial disclosure for the slides, and I'll take you through how to deal with traumatic optic neuropathy when you have the associated orbital injuries. So we know that there is the classification system that is very much in place, like what is direct tron and what is indirect tron. So majority of the time in our practice we see actually the indirect tron. So the direct tron is the optic nerve avulsion, optic nerve transection, optic nerve sheath hemorrhage, orbital hemorrhage that leads to the proptosis and external ophthalmoplegia, or the orbital emphysemas. So these are the entities where you are dealing with the direct tron. Otherwise, majority of our practice we see the patients with indirect tron. So what is the indirect tron? Basically, it is caused by the transmission of the forces to the optic nerve from a distant site without any over damage to the surrounding tissue structure, which is very important to understand. Dural sheath is tightly adherent to the periosteum, and the intracanalicular segment is particularly susceptible to the injury. So the intracanalicular portion of the optic nerve is close proximity to the falciform dural pole, and that is the next most common site of the injury leading to the tron, especially the brain injuries. So how to go about? So you have the option of the use of steroids, surgical decompression of optic nerve, or a combination of them, and the observation. But if you look at the literature, there is a lot of debate as far as even these treatment options and even the imaging. So if we talk about what is the best imaging in my hand, probably it's kind of a telltale balance between the MRI and the orbit. Samir has already alluded a lot about at what situation you would want to prefer the what investigation. So whenever there is a trauma, probably I would choose to do a CT scan of the orbit with kind of a 3D reconstruction what he has added upon. So what are the prognostic factors? We need to understand that visual acuity at presentation is extremely important at baseline. Loss of consciousness, lack of visual recovery after 48 hours, absence of visual evoke responses when you order the VEP, optic nerve, optic canal fracture, and direct tron. So if you know these prognostic factors, probably you would counsel your patient and will have the realistic expectations out of whatever the intervention you do. So we have the various regimes of steroid. Okay, starting from low dose to high dose to very high and the mega dose. There is a literature which talks about the different treatment modalities people have tried about. So this is an INTS study, indirect tron treated within 7 days of injury. Okay, again there is no significant difference between all the three groups that this study has looked for. There is no indication that either the dose or the timing of the steroid was associated with any increased probability of the visual recovery. This is an assist trial. We do have different segments like study 1, 2, 3, and the ultimate take home from this particular trial is that the optic nerve is predominantly a white matter tract and differs histologically from the spinal cord. So this is out of the picture as far as the ophthalmic practice is concerned. So then later on we do have a crash trial, again indirect tron patients treated within 8 hours of injury. So basically in this trial mega dose of IVMP was used, and at certain time point they have to terminate the trial because of risk of death and a severe disability. So surgical options, this optic nerve decompression, it could be a standard medial transorbital approach, transcranial, or the endonasal approach, and probably you plastic surgeons are the best guys to decide which approach is the best. So indications of surgeries, these are very much known indications, and you must know that the right now there is a very interesting review article by Dr. Gangadhar Sundar, who is presenting here, and he has written very nicely. So current understanding of the surgical management, there is no randomized control trial as of now, and accidental dural exposure CSF leak is very much common when you attempt to do these patients even through a endoscopic approach. So I'll take you through few cases. See, this guy 18-year-old had a RTA fall from bike. And then you can see that there is, the loss of vision in the right eye. You see the injury was from the left side. So that's how we need to understand. It's not necessarily, the site of injury would affect the site of, that similar side optic nerve. So no PL, and then, this is the fundus finding. Probably he had kind of a Berlin edema or Puschner's retinopathy, and this is the field. So treat these patients with IVMP and follow them up. So at 3-month follow-up, this patient improved 20/40. So now there is no guidelines, when should we start, but for my cutoff, whenever patient comes, within 72 hours is the best way. As much as, 1 week we can delay. That's how, the crash trial has done for. So that's how you can look. This is another patient 2 days back following collision with another bite. And then you see the 2020, both eyes, there was actually underlying tron. One eye has a moderate loss, one eye has a severe loss. Again, treat these patients with steroid, presented within 7 days. And you can see that, there is a remarkable improvement in the right eye, although there was no much improvement in the left. So what is the message I am trying to give it is, trauma was primarily to the left side in the first case, and there was a decreased vision was on the right side. So contralateral tron can occur. Second case, poor visual acuity at baseline proved to be, poor prognostic factor. So both the eyes had a differential response to the IVMP. This is a third case, 18-year-old male, again right eye, gross loss of vision. You can appreciate, you cannot see the fundus, what's going on with the disc. Is it really something like kind of, the optic nerve avulsion? It's very difficult. So what is the tool that we have in our practice? The B scan. So you will find that, the medium reflective, but the heterogenic echoes of membrane in the vitreous cavity, and then there is a cystic space above the optic nerve head is a clincher here to suspect, the probably underlying optic nerve avulsion. And you can always, confirm this by doing MRI scan, and then that would add the diagnosis. So this patient had undergone, the pars plana vitrectomy, and then that has eluded, the picture, what's going on inside. So basically there was a retinal thinning with cattle tracking, and then defect centrally in the optic nerve field with a gliotic tissue, which was suggestive of, the partial optic nerve avulsion, where, the prognosis is extremely poor. This is another case, fall from bike, reduced smell sensation is a clincher, again history, presenting like kind of subclinical tron. The disc looks to be, the pallor, because it presented almost 1 month after his primary trauma. And then look at this, the basic investigation, HV up, bilateral tron. Probably, this patient had actually kind of, the fracture that is floor of the anterior skull base extending to the chiasm, which is extremely rare. In a trauma leading to the bitemporal hemianopic field is extremely rare. And that's how the direct tron can present as an optic nerve avulsion or rarely fracture extending to the chiasma. Chiasmal trons can present as a bitemporal hemianopia, which are very, very rare in the literature. This is a 41-year-old male, collision with another bike, history of loss of consciousness, history of oral bleed after accident. Again, right eye, loss of vision, there was RAPD. You can appreciate here, there was a diffuse disc pallor, although the left eye was extremely subtle pallor. Then that's how this patient had, the altitudinal field defect in this eye. So basically, you treat this patient as per the standard protocol, and you would find, there is an improvement. So basically, the tron which is presenting or giving, the picture of kind of altitudinal field defect like ischemic optic neuropathy. This is a very interesting case. We had recently, sent it to a neuro-ophthalmology under review. So basically, this guy had injury to the left side of the orbit. As you can appreciate, there was a kind of a scar. But if you image this patient, there was obvious proptosis. If you image this patient, on fundus examination, we notice that there is a disc edema. And then that is the, indication for imaging. And there was a huge foreign body, hidden foreign body, which probably somebody would miss if you don't order what we have learned from today's IC. There was a foreign body, entering into the orbit and touching to the kind of supero-inferior half of the globe, and then that's how creating, the altitudinal visual field defect. So basically, you treated this under antibiotic cover because of, the non-organic nature of the foreign body. There was a lot of inflammation, probably possible risk of infection, and then you can appreciate that there was a remarkable improvement, even the altitudinal field defect gone after treatment with steroid under antibiotic cover. So that's how the mortality has also improved over a period of time. So the take home is TON can also present with variable field defects like altitudinal field defects, mass effect of the retroorbital foreign body. You need to keep in mind order HVF, order neuroimaging, and then this case also highlights the importance of imaging in ruling out compressive neuropathies in cases of trauma. Thank you very much.